Well, good morning, everybody. Welcome and happy Halloween. Glad to see you all here. And welcome to very special Grand Rounds this morning. We have Sam Hopkins, one of my favorite speakers. I'm going to introduce Dr. Hopkins. He grew up here in Portland, attended Oberlin College and the University of Virginia Medical School. He was an intern right here with us at Prov Portland, and then he did his dermatology residency at OHSU. He was also assistant program director of the dermatology residency at OHSU, and now he works for the Oregon Clinic, Portland Dermatology, and maintains a part-time position at OHSU where he co-directs the high-risk non-melanoma skin cancer clinic, which is a specialty clinic for organ transplant recipients and others at high risk for skin cancer due to immunosuppression or other risk factors. He's a wonderful speaker, and we're delighted to have him here with us. So please join me in welcoming Dr. Hopkins.
All right, thanks so much. I'm going to try and put this on real quick. If I can figure it out. All right, can you hear me okay? Pretty good in the back? All right, cool. Thanks for inviting me back to speak. I think it's been a few years since I was here, and it's always fun. I try and just keep things entertaining, present a lot of pictures and interesting cases, just because I've found that it's usually the most interesting dermatology talk to watch instead of a lot of text slides. I tried to spice things up a little bit just because of it being Halloween, and use some cases that seem to be theme appropriate. So hopefully you'll find it fun. All right, so I have no financial disclosures or any other disclosures other than my sister works here. So that's my relevant disclosure. All right, goals of my talk. So there's a bit of a refresher on describing morphology of skin conditions through interesting cases. So there'll be a lot of cases, and I'm going to try and describe how I would describe the cases like in my medical note as I'm looking at them, because I find that it's pretty helpful for non-dermatologists to hear over and over again. And then we'll go over different categories like infestations, rashes, growths, et cetera, so big categories. And I'm going to try and do a lot of pictures, very few text slides. And hopefully this is a reminder that dermatology grosses you out a bit and you decided to go in a different field of medicine for good reason. But hopefully you find it entertaining nonetheless. All right, so first section is creepy crawlies. So this was a patient who presented about a month ago to clinic, and he had older gentleman, 3-month history of itching on the trunk and groin, and he had gone to a few different providers, his primary care, urgent care, was given prednisone, topical steroids, antihistamines, but the itching wasn't improving. And I don't have a picture of his rash actually, but he was a very hairy guy, and essentially when he took his gown off, it looked like he had someone had grated a pepper shaker like over his trunk. So it was little dark dots scattered everywhere. And he said, you know, I feel like my pores are coming out. I have these little black specks everywhere, and I don't know what they are. And so, of course, I pulled one of those off and looked under the microscope, and it was this lovely pediculosis pubis organism or crab. And these are tricky because they are, usually you think about them in the groin, but if people are very hairy, they can go really anywhere. They have terminal hairs on the body. They don't tend to like the scalp. And they can also like the eyelashes, which is really creepy. And they hang on really tight by those claws. So these little hooks right here, they only hang on to the bottom of the hair follicle and then chomp away. So they actually don't move very much. So it's not one of those things that you will see something scurrying across the body. So you have to actually look closely and get in there and think about it. So similar theme, this patient had a several-month history also of this itchy rash on their scalp, neck, ears, very red and scaly. Were treated with dandruff shampoos, some topical steroids without a whole lot of relief, a little bit of comfort, but not much. And you can see it involves the ears. And we were thinking, you know, she has this diffuse erythematous, scaly eruption, somewhat ill-defined on the head and neck. And the first thing that comes to mind usually when we see this is it's going to be a contact dermatitis to a shampoo or fragrance or something like that. But when we zoomed in and looked closer, it became obvious that these little black specks were moving. So she had this horrific case of head lice and a secondary dermatitis related to the head lice or one of the products that she was using. Most of the time in an outpatient setting when I see head lice, it's very well put together. either teachers or young mothers, and they have a lice burden that's very minimal. So you find a few creepy crawlies behind their ears, or just the hair casts on the scalp. So you have to look very closely to find it typically. So this was the most dramatic case that I think I've seen. So I wish I had a video, because these guys really do move. And these are the ones that really freak me out, because I get in there and once I see it moving, I kind of like, okay, we're gonna just step back here. All right, this is a lovely young woman who returned from vacation in the Caribbean. And she had this erythematous eruption, mostly in the bikini area on the thighs and abdomen, of these squirrely or serpiginous erythematous plaques with a little bit of scale crusting. And she had just returned from the Caribbean about a week prior. And when you zoom in closely, you can see that there are these, what we would call serpiginous, so snake-like areas with some crust associated. You have different phases of time, so some that are kind of fading, other ones that are more active currently. And here's just a blow up here with another great example of just this very serpiginous or squirrely plaque. And so this is a good example of cutaneous larva migrans. So patients pick this up usually from visiting sandy places, parasitic infection that humans are an incidental host, so they tend to crawl along the skin here, eventually die. So without therapy, these patients usually it'll resolve, but you can treat them with ivermectin or other antiparasitic agents. So this is an example of something we see more commonly actually in dermatology. So these patients often come in and they have scaling, a little bit of crusting. If you look very closely, you often will find a little pustule. So how we would describe this is an erythematous thin plaque with scale crust and a few minute pustules. If you put this on the central face, the cheeks, the nose, it would resemble rosacea. And on the temples, one of my colleagues, Dr. Alexander at the clinic I work at, he taught me this, that when you see it more on the temples, it'd be worth KOHing one of these pustules, because at times you end up seeing Demodex organisms. And Demodex are common in all of our pores and follicles, particularly on sebaceous parts of our skin and our face. But when you see them in large colonies, when you scrape a KOH, that's unusual. And by treating with a medication that helps with Demodex, it can actually help reduce the rash. So in hindsight, a group of physicians decided to study topical ivermectin for treating any patient with rosacea, thinking that some patients with rosacea might just have a Demodex folliculitis, and they might see benefit. And what's interesting about that, they used topical ivermectin, and they did not prove whether the patients had Demodex or not. They just treated anyone with rosacea that had pustular rosacea with topical ivermectin, saw improvement. So the conclusion of that is really that some patients with rosacea probably have some benefit from reducing their mite burden in their pores or Demodex, thought being that rosacea might be an inflammatory reaction to some of their own flora. But when we see it more on the lateral temples, forehead, and they have a huge mite burden, then I usually will treat with either topical permethrin or topical ivermectin, and usually the patients see improvement. This was a lovely young woman who came in, and she had a 3-4 week history of this rash on her nose and upper eyelid and brow. Quite itchy, had started somewhat centrally and had started to spread outward. And from this other angle, you can kind of appreciate that it is pretty annular and has scaling at the peripheral edge. So we would describe this as an erythematous annular thin plaque with scale at the leading edge, and it involves the eyelid down here too. And so this was tinea corporis, or tinea faciei when it involves the face, so ringworm, but an unusual location for it. And sometimes the story will be that the patient has a new kitten at home or a new puppy, but other times it can be self-transferred from the feet from tinea pedis. So an unusual presentation of tinea. So this patient was also a return traveler, so 38-year-old guy who came in with a sore bump on the abdomen, been present for a few weeks after returning from a medical mission trip to Central America. And at first, when you look at the area, you think common things being common. Is this an inflamed pore? Is it a cyst that's inflamed, so a follicular cyst? Or is it a staph abscess or furuncle? And so you decide to numb it up and incise it and see if you get pus that comes out. But instead, it's your lucky day, and you get this little organism here. So this is a botfly larvae, and we see every week we see cutaneous abscesses and inflamed cysts that we have to drain, and it's a fun day when a larva comes out instead. So I've had a handful of these cases in my career, and they're always fun. And what's interesting is that I've had a few patients where they literally come in and say, "I have a botfly larva," or they've had it before. There are people that go on these mission trips and they've had this before, and they say, I had it once before, I know that's what it is, the timing's right, and sure enough, they're usually right. So these are interesting. The story behind how these occur is fascinating, and it's like you can't make this stuff up. But so apparently, what happens is there's the vector organism, I think, which is Dermatology hominis. It is a fly. It actually catches a mosquito in the air, lays its eggs on the mosquito. The mosquito then bites the person. The eggs travel into the person, and then over the course of several weeks mature into a larva that feeds off you. But they keep this little hole, this little air hole here. That's their little feeding hole. So they won't travel any deeper than the skin than that because they have to keep that oxygen source. And so the different treatments are usually incising and draining, pulling it out. And then this is also one of those things where people have talked about putting bacon or a slab of meat on the skin, encourage the organism to find a better meal. But yeah, we don't carry bacon in the clinic, unfortunately. Okay, so that's all the creepy crawly organism stuff. So I'll move on. So we see a ton of tattoos in Portland, as I'm sure you guys do too. If you get people undressed, it's pretty amazing what people have on their skin. Some beautiful tattoos. But and what's amazing is how often this is done, getting tattoos, and how infrequent we see problems. But they occasionally come up. So this was a woman who came in about a year ago, and she had gotten this spiral tattoo with red and black ink on her forearm. And several weeks later, it started to itch. It was getting inflamed and crusted. And so this is sort of different phases. Started out just subtly raised and red, then became a little bit raised red and a little bit of fissuring and crusting, and then really crusting and weeping over here off to the side. And so the question is, is this infected? Is it some sort of an immune reaction? And so we ended up doing biopsies from a couple different spots within the tattoo, trying to pick the areas that were the most inflamed or crusted, and tried to evaluate and send for tissue culture as well as histology. And the pathology ended up being, the infectious workup was negative, fortunately, and or unfortunately, depending on how you look at it. And the pathology was best for an allergic reaction to the dye. And when we see allergic reaction to the inks and tattoos, it's typically the red color for some reason, red or yellow. The other colors don't react quite as much in terms of an allergic reaction. The challenge with this is that there's no great solution. You have this permanent ink deposit in the skin that you're having an immune reaction to, and so what do you do about it? So people have done things ranging from trying to cut the ink out, cutting it out, which if this covers, the entire volar portion of your forearm, it's not going to be great. You'd have to do a large excision and grafting. Topical steroids, injections of steroids, just hoping that the immune system stops reacting. That was not helpful for her. We tried that initially. And then ultimately what we ended up deciding to do with some trepidation is try and do laser tattoo removal. And the reason there's some trepidation, there's been some rare reports of doing laser tattoo removal, but somehow you're releasing that antigen from probably it being enclosed by histiocytes and inflammatory cells, and patients having like an anaphylactic reaction. So we have to be a little cautious. She fortunately has seen actually great improvement with doing the laser tattoo removal. I'm not doing it myself, but I had a colleague do it, and seems to be finding it beneficial. So be careful what you wish for. This was a different patient, obviously different tattoos, and he came in and his story was different. He had tattoos placed years ago, and then all of a sudden, the last 6 months, he was getting bumps within the old tattoos. So what was going on there? The bumps themselves were not particularly uncomfortable, but some of them were covering really whole sections of tattoos. So like these, I think these are letters. The whole part of that ink was inflamed, raised, like a thick plaque, but confined and really discreet and not involving the skin around it on some of those areas. But he did have some new nodules that were developing outside the tattoos as well. So he had what we would describe as dermal, erythematous, papules and plaques, both within tattoo ink and not restricted to it. And so we did biopsies, both of one within the tattoo ink and also one of these that's not within the ink to evaluate to see what was going on. And he ended up having sarcoidosis presenting in a tattoo. And this has been reported in the literature where for some reason patients who have sarcoidosis, as sometimes the presenting factor or later on, they get sarcoidal granulomas around the foreign body material of the ink. And if we just see the sarcoidal granulomas in the tattoo alone, it becomes very challenging to determine is it sarcoid or is it just a sarcoidal inflammatory reaction to a foreign body or a histiocytic reaction to foreign material. But when you have nodules that are outside the primary, then it becomes more clear that it's likely sarcoidosis. His systemic workups for sarcoid was negative, fortunately, but he's still being followed by his primary care over time. These were not terribly bothersome for him, so it's a little challenging when it's widespread on what to do for therapy. It can range from topical steroids or injectable steroids to systemic medications like methotrexates, TNF antagonists have been used, but you're always balancing whether it's worth doing if it's just a skin rash or not. So one more tattoo. This was Happy Buddha. And Happy Buddha was placed, and then several weeks later, the patient started noticing these tiny little pink bumps within Buddha's skin here. And so I showed this picture to my colleague the other day because she came in while I was flipping through these slides, and she said, "Oh, Buddha has chicken pox." So these weren't particularly bothersome to the patient, maybe a little itchy, and she had tried some topical cortisone on it without a whole lot of benefit. And the bumps were somewhat concentrated around where the ink was sort of this faded gray color, but seemed to be starting to spread outside of that too. And I don't know if I have a picture showing it, but there were some bumps that started extending outside the tattoo over time, so started to spread beyond just the ink. And so just like in the other cases, the consideration is it an inflammatory reaction, immune response, an infection. It didn't seem like allergy to the dye was a good fit just because of it was extending outside the ink. And what this ended up being was an atypical mycobacterial infection from contaminated ink. And this came up in the literature maybe 10, 15 years ago. There were several reported cases of this where what was happening, we think in hindsight, was the dark black ink. Some tattoo artists, what they do to get gradients of black for shades, they dilute the black ink, with water at different concentrations so that they get a dark black, gray, light gray, et cetera, and they get these beautiful gradients. But obviously, if either the source ink itself or the water that they're using to dilute it is not sterile or contaminated, then you can get an infection through the tattoo process. And that's what happened with her. And so she referred her to an infectious disease colleague who ended up treating her, and she did fine. So the three things that I think about for tattoo reactions, it's allergy to ink, granulomatous reactions like sarcoidosis, or infections. And we don't tend to see the acute infections in dermatology, which are probably most likely like minor staph infections and things like that, complicating wounds. But tattoo artists, get some training on sterilization technique and things like that. So they do a pretty good job for keeping the areas clean. All right, so next section, food, drugs, and lack thereof, appropriate for today's candy. So this patient came in and said, I have these weird stripes on my skin that just suddenly came out over the last few days. They're red, they're a little bit itchy, they're a little swollen. And you look, and it looks like someone, whipped the person or lashed them, or they really scratched themselves deeply. And this has been a pattern that's been called flagellate. So these strips and stripes in a pattern. So here's a couple up here too. So erythematous, geometric, linear, grouped plaques. Several day history. Had some others that were a little bit more squirrely on the arms. And you can see also this kind of striping on the back, like someone either grazed something or something was struck across the skin. But in this case, he denied any sort of contact that he could wear. He didn't think he had scratched these areas initially. He wasn't doing yard work, no hiking. Really had just been going about his business, normal life. But when you dug in his history a little bit, you're like, what have you been eating over the last several days? Have you cooked with anything in particular? And it turned out, this is one of those things you have to know it to ask the question, have you cooked with shiitake mushrooms at all recently? Oh yeah, like a couple days ago, we made pasta with shiitake mushrooms. And this has been reported as a reaction to shiitake mushrooms if they're undercooked. It's really fascinating. I don't think anyone quite understands exactly what happens, but this has been called shiitake dermatitis. When we see this pattern of these almost like whipped-like streaks on the skin, the things we think about are poison oak, so a plant allergy that you come across grazing. And then the other two things that come up, bleomycin can do this too, where you get chemotherapy with bleomycin and you get this flagellate erythema, is what it's been called, flagellate erythema, or shiitake mushrooms. And typically in outpatient dermatology, it's shiitake mushrooms. And it's not that common, but we see probably a case every 6 months in Portland. And it's always a fun case because it's one of those things where you can have an aha moment with the patient and they're going to be fine too. So it comes up probably a day or two later after the exposure. Shouldn't happen if the mushrooms are really well cooked, and it probably doesn't happen for every person. So it probably has to be host dependent in undercooked shiitake mushrooms. So that one's fun. Okay, much more dramatic. So this is a hospitalized patient over at Emmanuel that I was called to consult on, and she had this widespread acute eruption, and it was characterized by these erythematous to dusky plaques scattered all over the trunk predominantly, but obviously over the buttocks, proximal extremities. The centers were a little bit more dusky than the periphery, and so this is an example of a case where you have to take a step back and then take a step forward. So at first you kind of zoom out and say, oh wow, this is really widespread, and then you have to go close and figure out, okay, can I zoom in and find a clue if I get really close to this eruption? So it started several days after she was switched to oxcarbazepine as a medication, and so she was pretty concerned it was related to that drug, and she was spot on. And when you zoomed in, at the edges of these really intensely erythematous to dusky plaques were these tiny little pustules, so little tiny white pustules. And so these tiny white pustules sort of almost loculating together, studying these plaques is a pretty classic presentation for an unusual and rare drug eruption that we call acute generalized, those two words are helpful, exanthematous, because it can be a little bit eczema-like at times, pustulosis. So it's one of those gobbledygook dermatology diagnoses, but each word actually helps. So it's acute, it's widespread, it can be erythematous like a lot of exanthems can be, and the little tiny pustules are really the giveaway. So acute generalized exanthematous pustulosis. And AGEP, as we like to call it, it's a severe drug eruption because it can be widespread. Patients can feel miserable. They can have low-grade fever. It often occurs very early on, so within 2 to 3 days of starting a medication, so a pretty acute onset. And the diffuse redness studded with these tiny little pustules is really the key. Patients can have lab abnormalities with neutrophilia or eosinophilia, but they don't always have eosinophilia, so you have to be still cognizant that not all drug eruptions will present with elevated eos. And the management is just withdrawal and then supportive care. They turn around pretty quickly just with topical steroids and getting them off the bempenetic agent. So this is a more classic eruption that we all worry about, and this young gentleman was started on lamotrigine 1 week ago, and he has this desquamation of the lips, so hemorrhagic crusting of the outside of the lips. So this is kind of a classic presentation of Stevens-Johnson syndrome, just a good reminder. The other thing we see with this same presentation with hemorrhagic crusting on the lips is, which is also rare, is paraneoplastic pemphigus. So patients who have underlying malignancy sometimes can present with a form of pemphigus that presents a little differently in that they tend to have this terrible crusting on the lips. So that's the other thing we think about. So if they don't have a drug to blame, and they're getting a lot of hemorrhagic crusting, certainly if they're getting other skin findings, get a dermatology consult. This was an unfortunate gentleman who presented to the hospital, and he came in with several-day history of worsening rash. The skin felt painful, tender. It was very inflamed. He had essentially redness head to toe, so erythroderma. Some of the areas were very intensely dusky as well. He had been started on allopurinol about 3 weeks prior to onset. And now he had not only the rash, but fever, transaminitis, and eosinophilia. So he had obviously something pretty significant going on. When you zoom down on his eruption, he had these erythematous to dark, dusky plaques, and they're sort of an accentuation of his follicles, so sort of a swellingness of the follicles almost. So we call that follicular accentuation. It's a little bit like it was keratosis pilaris, but acutely thickened. And you can see here it's covering his whole trunk as well. I don't have a picture of his face just for his sake, but he also had facial edema, which is a really helpful clue. So he felt like his face was swollen, his hands were swollen, his skin was on fire. He had palpable lymphadenopathy, febrile, labs were quite abnormal, very elevated LFTs. And he had DRESS syndrome, so drug rash with eosinophilia and systemic symptoms. So this also goes by drug hypersensitivity syndrome, and the DRESS is what dermatologists know it best by, which stands for drug rash, eosinophilia, which is usually present but not always, and then systemic symptoms are variable but present. So usually these patients have a widespread eruption initially. It often starts more on the head and neck, and then will spread peripherally. They will have low-grade fevers or even high-grade fevers, and then the systemic symptoms can be variable. The helpful exam clues for me when I hear if someone calls on the phone with this consult and they say widespread rash with fever, I like to ask if they have, is it on the face? Do they have facial swelling? Are their hands swollen? And then what their lab changes are. And I find that that's a pretty helpful clue that tells me that I'm pretty worried about that this might be a more serious drug eruption. And the big offenders are kind of a theme in dermatology for rashes that are drug-mediated: anticonvulsants, sulfonamides, and allopurinol. So those three categories are the ones that cause worrisome skin eruptions, or the big three, although you always have to think about other ones. Even Tylenol has been reported to be associated with DRESS. So complications, hepatitis is the most common one. Delayed thyroiditis has been reported, so it's recommended to check their thyroid TSH 6 or 12 weeks after baseline checking. And then rarely eosinophilic myocarditis, pneumonitis, interstitial nephritis, encephalitis, and SIADH. And this patient did quite well for 3 or 4 weeks, but then he unfortunately presented with myocarditis and passed away. So it was super sad. And the first case I've had that patient died from it. Okay, this patient was fascinating. The first time I'd seen this, she presented a day or two after having a cardiac procedure where she had a defibrillator placed, and she had a rash, low-grade fever, and myalgia. She felt really crappy. The rash came on very quickly. She described it as these swollen knots that were tender on her elbows and knees, and so came back to the ER essentially where she had had her procedure done, said, I think something is amiss. And she had involvement also of her volar wrists, so edematous, indurated plaques and nodules. And during the procedure, this wasn't something I realized they do now, but this is pretty common per the cardiologist, but they put an antibiotic-eluting envelope that's placed around the defibrillator that dissolves over time, I guess, but it's placed to reduce infection from around the leads, reduce the chance that you get myocarditis and things like that. So, and in these envelopes, I'm guessing there's multiple on the market, but the main one, the one that was used in her case, included minocycline with rifampin. So two antibiotics in this drug-eluting envelope. And so what we ended up concluding that she had was a serum sickness-like reaction. And serum sickness-like reactions are an immune complex process where a patient develops antibodies to the antibiotic or the antigen that lead to an acute inflammatory reaction. And so they typically get low-grade fevers, they get skin findings like rash. The rash can be somewhat urticarial, but will often be pretty intense, tender, sometimes rather than itching. So I hadn't seen this before. I've never seen serum sickness-like reaction prior, but I thought that was pretty fascinating. So she ended up having that. They went back in actually and took the pouch out and ended up replacing it with a non-antibiotic eluting stent. And the culprit for this one, I'm pretty sure, is minocycline, because minocycline's been reported to have serum sickness-like reactions at times and other weird drug eruptions. Okay, so not drug for this one. So this patient was also in the hospital, and she had been admitted several times with sort of failure to thrive, diarrhea, and a rash. And she had a history of gastric bypass, and this was like her third or fourth hospitalization within the year. And on exam, she had these sort of erythematous to violaceous, scaly patches, thin plaques in the intertriginous areas predominantly, so inner thighs, under the breast. The scale at the areas was almost like it was peeling off, so what I would describe as sort of desquamative. And the patches and plaques themselves were sort of somewhat ill-defined, irregular in shape, but the distribution involving sort of these intertriginous spaces, the groin, under the breasts, elbows, and then she also had nail changes and some crusting around her mouth. And then this is just a good picture just of her umbilicus, where she has this plaque where there's scaling, crusting, sort of a fragility to the skin appearance. And what this ended up being was acquired acrodermatitis enteropathica. And acrodermatitis enteropathica, when it's genetic, is related to an enzyme deficiency that inhibits zinc absorption. But it's most commonly we see it as an acquired malabsorption condition. And what was going on for her is that she, as a product of her gastric bypass and her new physiology with that, she was having some diarrhea, some wasting, and malabsorption, and her zinc levels came back super low. So she would come in, she would get vitamin replacement and things like that. Her rash would clear up, she'd go home, and then this process would go on again. So essentially we had to get her gastric surgeon involved in endocrinology, but I can't remember, and to try and figure out, okay, well, what can be done in terms of her either diet or whether further surgery or revision needs to be done. So pretty interesting. So we see similar eruptions to this from other vitamin deficiencies, but zinc is probably the most common one. The cool thing about this is you give zinc replacement and they turn around very quickly. So that you can see the rash clear up within a couple days, which is very fast for skin eruptions. Okay, so this was a fun case that my colleague shared with me. This was a patient who came in and he said, all of a sudden I have this brown, weird-shaped rash on my leg, and you can see it's sort of an odd shape. It's red in the center, it's somewhat hyperpigmented around the outside, and if you kind of just imagine it looks like someone's handprint. And my son was drinking limeade, was the history that we were able to get. And this is an example of phytophotodermatitis. So phytophotodermatitis is a fun one. It's caused usually by limes is the most common exposure, or other things in the citrus family, where patients get usually splashings of the lime juice on their skin, and then they are exposed to sun. And the combination of the sunlight, the photo, and the plant, phyto, you get this inflammatory reaction. Sometimes patients present in the acute phase when it's really red, but it'll still be an odd pattern. So what we would call, it's a weird geometry, it's a weird shape, it must be an outside job. This is not something that typically happens internally. The exception being that shiitake dermatitis thing, which presents similarly. So a weird pattern. Acutely, early on, if you see it, it'll be red, but patients often don't even notice this because sometimes it's not symptomatic, but it could be itchy. So sometimes patients come in, 2-3 weeks later, and they just have this weird brown streak. They finally got in. They've been watching it. It doesn't bother them. It's not getting any worse, and maybe it's getting a little better. So it's kind of that pattern. So usually there's one of those other diagnoses where you see it, you think, the color, it's sort of this brownish color, a little bit of redness, and it's a weird pattern. I wonder if it's a lime exposure. And the classic one is, making margaritas and you squirted limes all over your hands while you're in Mexico, and now you have this weird rash when you got home a week later on your hands. But so it's one of those other ones that once you see it and know it, it's fun to ask the questions because sometimes you can get to the bottom of it. Phytophotodermatitis. All right, trick or treat, don't be fooled again. So I have a few infectious mimickers. So this is a great example of a diagnosis that we see every several months, so not very common in dermatology. but usually has been misdiagnosed, and patients have seen multiple providers before they make their way in to see us. They present with annular or arcuate erythematous thin plaques with scale. And so the first thing that comes to mind for everyone is always a tinea infection or fungal infection. And so we always have the benefit of hindsight when patients come in and they've already been on topical antifungals, oral antifungals, multiple versions thereof, and the rash just has not gotten better. It usually itches a little bit. It'll spread, come and go to some extent. So sometimes it does start centrally and expand outwardly, just like a fungal infection, which adds to the mystery of this condition. And this is a condition we call erythema annulare centrifugum, another jumble of words that's actually useful. So erythema because it's red, annular because it is ring-like, and centrifugum because it spreads outward. The difference between this and tinea is that the scale in this is a trailing scale rather than a leading edge scale. So if this was tinea corporis, we usually expect scale all the way out at the periphery, and maybe it then is no longer as present centrally, whereas this condition, you end up having this leading edge of pink or redness, and the scale is slightly trailing. The other thing that does trailing scale is pityriasis rosea, but that presents very differently as more oval patches on the trunk in a Christmas tree pattern. This condition can be on the trunk or extremities. It can be an isolated lesion or multiple spots. We consider it a reactive erythema just because we don't typically know exactly what's driving it, but there have been reports of this being triggered by remote infections like chronic sinusitis. People have actually been reported having this as the trigger from onychomycosis. So weird that you get a remote fungal infection that causes this fungal-like eruption that'll be more on the trunk and extremities. If you KOH this, it's negative. If you culture it, it's negative. So it's a fun one, good to know about. We treat with topical steroids like we treat most things, and it goes away. This is a patient who presented. He has a history of AML, and he now has a new rash and low-grade fevers. And his rash came on acutely. The spots themselves are somewhat tender, and we would describe these as juicy edematous plaques with crusting, and they're often described as pseudovesicular because they're so swollen and acutely that they look glistening, almost like there's fluid in them, but there typically is not. So pseudovesicular plaques with crusting scattered on the trunk in a gentleman with a hematologic malignancy. And this type of presentation in the right clinical context with a patient with AML in particular, which is a classic disease association, especially if they have low-grade fevers, this is a good presentation for Sweet syndrome, which is also known as febrile neutrophilic dermatosis. And the pseudovesicular plaques is sort of the hallmark or a key word that we use in dermatology. And what we mean by that is that it looks shiny, it's inflamed, it's acutely raised, and you want it to have fluid in it, but when you palpate it, it's clearly not. It's just a slightly indurated edematous plaque. All right, so this was the patient who was in the hospital, 52-year-old hospitalized patient who was presenting for fever of unknown origin, getting worked up for that, and now after a day or so was noted to have blisters in the axilla. So dermatology was consulted, worried that these vesicles could be the explanation for her fever. Could this be disseminated zoster, disseminated herpes? And so can we come take a look? And these were these very tiny vesicles, clear fluid, actually kind of tense, so firm, not like a soft, squishy blister. And they came on suddenly. She'd been having fevers. She'd been bedridden, high fevers. And what these ended up being, so here's just a better picture with the blow-up. You can see it's kind of neat, mostly just confined to the axilla for her, so not widespread. And these tiny, glistening, perfectly non-inflammatory, so no surrounding erythema vesicles. If this was disseminated zoster or disseminated herpes, typically you'll have the vesicle, but it'll be on an erythematous base, so that's the key kind of tagline there. And this is a form of heat rash. So this is miliaria crystallina. The crystallina so named because this variant has these tiny, beautiful little vesicles that are confined to overlying the sweat ducts, and it's an acute occlusion of sweat ducts, usually associated with high fever, sweating, that type of thing. So it's a fun case, so I don't see it very often. It's probably missed most of the time when it happens and probably self-resolves. for patients. There's no real treatment for it other than trying to manage the fever. So this is a patient who presented with tender swollen toe for a week. So this is sort of probably something primary care providers get to see and I rarely get to see. So when they presented to me, it was kind of fun. And I said, go see your primary care provider. So they had gout. Yeah. This is a case, this also usually is misdiagnosed for a while as a tinea or fungal infection in the groin. So this patient had 8, 9, 10-month history of this eruption in the groin folds, but also the armpits, and had tried antifungal creams, antifungal powders, wasn't really helping. Tried some topical cortisone as well. That didn't help either. So this condition presents in the groin and armpits, so the warm, sweaty areas. Tinea cruris, if we see it in the groin and you see this redness, erythema, it's usually not quite as deep color as this, so it's usually more of a faint redness, and the scale will be at the leading edge like we've talked about. You can also see irritant dermatitis in the groin where we just see more bright red, usually more confined to the skin creases where the skin is rubbing. This condition tends to have more of a red-brown look, so it's this reddish-brown or more sort of a deeper red or a copper red appearance. It'll have some fine scale, won't have a leading edge to scale. Typically patients will have tried antifungals. And then seeing it not only in the groin but the armpit's helpful. And then if we get a black light and we fluoresce the skin, if they haven't really scrubbed up that day, so if they haven't cleaned too thoroughly and you get lucky, you can see this fluorescing kind of red color. I don't know if it's projecting super well, but this is a sort of diagnostic finding when we see rashes that are sort of a brownish red in the groin and armpits, and this is a form of corynebacterial infection of the groin that tends to like the warm, sweaty areas called erythrasma, and it's treated with topical erythromycin, and patients do fine. It's not risky. I think a lot of people probably have this, don't know it, don't need to know it, and they're fine, but it's a good one to know about. Okay, next category, things that are weepy. So this is a pretty classic case of a guy who comes in. He has history of ulcerative colitis and now has a leg ulcer that's expanding. It's painful. And when you zoom in, it is open. It's an ulcer. It's weeping. At the peripheral edge, there's a helpful clue for this, which is this overhanging violaceous rim. And this is a classic case of pyoderma gangrenosum. So this is sort of like the textbook pyoderma gangrenosum, where you have a new ulcer, a patient who has an underlying risk factor. The risk factors for this are often inflammatory bowel disease, rheumatoid arthritis, and it often will be started at an area of trauma. So it's a condition that worsens with trauma. What can happen, where this can go wrong, is it can be seen as an ulcer, worry about infection, and it gets debrided and then it worsens after debridement. If cultures are done just as like swabs of the surface, you get a lot of contaminant because it's an open ulcer. So it can also be misdiagnosed as infection, treated for a while it worsens, worrying that you have a more rare infection and you're missing that. So this overhanging violaceous rim, right clinical context, is a helpful exam clue. So this is in the same theme. This is a patient who has myelodysplastic syndrome and presented now with a new painful sore in their armpit. And let's see if we can zoom in, yeah. So this similarly has this violaceous border. Not a true ulceration, but a lot of crusting throughout the whole area. And this is actually this very fine, thin scale here that's almost like what people have described as sort of the vapor trail of a blister. So like a blister that was so fragile that it just rubbed off, which you can imagine if you had a fragile blister in your armpit, it's not going to stay as a blister very long because of just swinging your arms. So this intense violaceous color at the periphery, hemorrhagic crusting, this sort of vapor trail of a blister. This is an atypical presentation of Sweet syndrome, where patients with hematologic malignancies have been reported to have this, where they get, instead of those pseudovesicular plaques, they actually get edematous, almost bullous lesions, but the bulla are so fragile that they break down very quickly, and you just get this crusting across the top. So this is a helpful kind of example of an atypical presentation of a neutrophilic dermatosis, which pyoderma gangrenosum and Sweet syndrome are considered in that category. So this is a young kid who had a history of eczema and he presented from his parents to the emergency department because his eczema was suddenly worse and painful, and had spread across his face very quickly. He prior to that had just had eczema kind of around his mouth and the perioral area, which is pretty typical for kids at this age who are messy eaters to have, if they have eczema, to have trouble getting clear there. And the story for this, the helpful exam clues for this is obviously he has a lot of honey-colored crusting, and typically patients will come in and potentially get misdiagnosis just having a staph secondary infection, because they do have secondary staph infection over all this crusting skin. If you swab the skin, it will grow staph, and they need to be covered for that treatment-wise. But then scattered around the periphery, all these tiny punched out 1 to 2 millimeter, 3 millimeter ulcers. If you're lucky, sometimes you'll see an intact vesicle, but these essentially did vesiculate but then crusted over very quickly and broke down. And the story with this is usually kiddo with eczema, grandpa came over who had a cold sore, kissed the kid with eczema, first exposure to herpes simplex, and then herpes spread across the skin very quickly like wildfire. So this is called eczema herpeticum, and it's a cutaneous disseminated herpes infection, and usually a host that has a compromised skin barrier. So eczema is the classic, but you can also see it as complicating burn injuries. It's been reported in patients who get ablative laser procedures or other procedures where the skin becomes raw or open. So it's an important thing to recognize, and those punched out ulcers scattered about the periphery are really the key. All right, changing gears. We're going to do a few growths to wrap up here. So I thought this was the most Halloween-y picture I could find, courtesy of a colleague of mine, and when I sent out the request for gross pictures. So this old gentleman, comes in. This has been there for a while, but now it's blocking my vision. So why do people present? It's always interesting. So finally got to the point where it's bugging him. So I think I'll come in now. So this is called a cutaneous horn. This is a column of hyperkeratosis. It's hard and pretty well attached here, otherwise he would have been able to pick it off pretty well. And at the base, there's typically a growth. So at the base of cutaneous horn will be one of three things typically: a squamous cell carcinoma, which is the most common one, which this is, a wart, or sometimes just an actinic keratosis or precancerous lesion. So those are the three things we think about, but this clinical context, an older patient, sun-damaged skin, head and neck, squamous cell carcinoma almost 100% of the time. But just a great example. This one's kind of fun one. So this patient, healthy woman comes in. She has this spot on her ear that she just hates because this hair keeps growing out of it. And she'll clip it off, and it just keeps growing and growing and growing. It's super annoying. She wants it gone. And there is a bump that you can feel at the base here. So there's sort of a pink papule with an opening, follicular-based opening, and these long, beautifully long gray hairs coming out. And this is a benign growth. It's one of those bizarre skin things like, why do I get this? I don't know. Sorry you got this kind of thing, but you're fine. It's called a trichofolliculoma. It's a pathology diagnosis, so meaning we take it off, we send it in, and there's patterns of the cells that have formed this growth that are of the follicle origin that stimulate this abnormal hair growth. So just a fun one. So there's a patient who presented with a few month history of this enlarging mass on his scalp. This is the kind of case where the patient comes in with a hat on and they say, I have something on my head, and you're not sure what's going to happen when they take their hat off. Sometimes there's barely anything, and then sometimes this happens, So this is a presentation of a lymphoma to the skin, and sometimes these happen as primary lymphomas of the skin, or they can happen as skin involvement of a generalized lymphoma or systemic lymphoma. This one ended up being a B-cell lymphoma of the scalp. So when we see this, we biopsy, we make the diagnosis, and then we send to oncology for treatment and for a further workup. And this was a fun case. This was a young gentleman with Down syndrome brought in by his family, and he had these thick scales on his legs. His trunk had been going on for years. Had not really been able to get treatment because of access to care limitations, but we see patients through Project Access at our clinic, and so he came in through that avenue. And So his legs, he has this incredibly hyperkeratotic scale. It's like he's got a shin guard on. It's really impressive. And his back, the scaling's not quite as thick, so you can see that these are actually erythematous, well-demarcated plaques, but very widespread with associated scaling. But without any treatment, any topical moisturizer or anything like that, the scale can gradually thicken in this condition. And you can see it does involve the periumbilical skin where he has this thick, incredibly thick scale still present, but then other areas with less thick scale. And so this is psoriasis, just like psoriasis, untreated, dramatic, thick scale. People have termed this ostraceous scale or rupeal scale. And we don't see it very often because most people don't let it get that bad. And a lot of people can keep the scale down just through scrubbing or washing to some extent. He did really great actually just on methotrexate and cleared up over probably 70% of these areas and was quite happy. I haven't seen him in a while, so hopefully he's able to get care of other places. All right, so I'm going to end there. If folks have questions, I'm happy to take them for a little bit, and then I'll go from there. So happy Halloween, everybody, if you have to leave. Yeah. Thank you. Yeah. Yeah, well, things look different depending on their skin type. Portland, for all of its wonderfulness, we have a limit in how many patients with darker skin we see. So one of the negative feedbacks for the dermatology department in Oregon is that the residents don't get exposure to darker skin types. So, but when we see patients with darker skin types, the redness looks different. It won't be. It'll be a deeper color usually of redness. I mean, there's going to be unifying features, so the distribution of skin rashes will be the same. So it'll still like the elbows and knees. They'll still be red, but if it's an inflammatory condition, but it'll be a different shade of red if you have a very dark patient of African American descent or a patient of Latino descent or Asian descent will look different. The other changes we see is a lot of pigmentation abnormalities, so meaning that, or abnormalities are just alterations that patients hate, I should say, where after inflammation they'll get staining of their skin, where the rash goes away and then they have a dark patch that lasts for months, and that's very frustrating. And a lot of time there's just sort of hand holding. There's some things that can be tried, but so yeah, it's a challenge. Yeah, especially if you don't train in a place where you get to take care of folks who have different skin types. So that's one of the limitations sometimes in Oregon. Yeah. Yeah. Yeah, the thought is that with tattoo laser removal, the thought is that you're breaking, if you biopsy the skin with a tattoo, you see little ink globules that are encompassed by histiocytes. So the histiocytes surround foreign material. And just like shrapnel, patients come in, they're in the war and they had a piece of material lodged in their skin, it's been there forever, it's not causing harm. So the body walls off these foreign materials. And you still get to see them because they're close enough to the skin surface. So the thought is when you use laser, you're targeting the pigment-specific color with energy and rupturing that pigment into smaller pieces. And then hopefully the body then engulfs those smaller pieces and somehow gets rid of it. So circulates that pigment and extrudes it. Or it may just be invisible at that point for the naked eye. Yeah. When people get tattoo laser removal, you can still tell where they had the tattoo. It's not that their skin looks perfect. It just usually fades things, and sometimes you see sort of the shape of the tattoo in discolored skin. Yep.
About the issue of the tattoo as well, I read somewhere that some red dyes are made out of red beetle. Do you know what are the sources of the pigment in tattoo dye?
Yeah, my understanding I don't know all the sources, but the red dye, my understanding is that it's usually cadmium based, is my memory on that one. And for some reason that metal is more allergy stimulating. So certain metals we see a lot of common allergy to, nickel being the classic one, but rarely you can see allergy to other metals. So a lot of pigments are made from earth, metals and things like that. So my understanding is red dye is typically from cadmium or cadmium blends, blended with other things. Yeah.
Can you comment on the cost of laser tattoo removal versus the
Yeah, I don't know what it's going for currently. We don't do it at our clinic. I don't do laser procedures myself, so I don't do really cosmetic stuff. It's never covered through insurance. But I do know that like project or what is it? Outside In, they do like free tattoo laser removal there. But I think you have to be homeless. Yeah. To have access to that. So there are some resources for folks. There's some services and nonprofits that are doing, I think, like laser tattoo removal for gang tattoos, gang-related tattoos, things like that. So there's some cool stuff, but otherwise, I'm sure it's not cheap. Usually, most laser procedures cost a few $100s per session. Yeah, and it takes probably 20 sessions to remove a tattoo, 10 to 20. Mm-hmm.
Thank you very much for a great Halloween presentation.
Yeah.
My question is actually more generalized to dermatology because I think more than any other specialty, my patients come in saying, I want to see a dermatologist out of lots. And, I like to treat, like to at least try something. Can you just give us a perspective from your standpoint? When is the right time for primary care or dermatology?
Yeah, I think if you have a sense of what you're treating, you should go for it. If you feel comfortable. So I think kind of just depends on how comfortable the primary care provider is with dermatology, because we see patients get referred in without having done any treatment for a rash. They saw primary, and it was probably an aside after like problem 10. After being seen for like diabetes, high blood pressure, and blah blah management. Oh yeah, I have this rash, and your appointment's over. Why don't we see dermatology? So that happens, I think, commonly. But if they come in for their primary problem, and you're able to make a diagnosis at least with some confidence, or your differential diagnosis of 2 or 3 things that has a comparable treatment, like I think this is either mild eczema or mild psoriasis, I would say treat, or if you think most likely it's tinea corporis or a fungal infection, there's really not great risk in treating with topical antifungals other than if it doesn't work. And, we just see the treatment failures, I'm sure. So I assume that many times, it is fungal infection and the patients don't come back to see you or me, that type of thing. So I don't know if that gives you great guidance, but yeah.
My question was, what do you see? I mean, do you see 70% de novo rashes where it's the 10th problem, or is it 70 or 80% treatment failures?
Yeah, it's probably, for people who come in with rashes, I would say the majority of them have had some treatment. Not uncommonly these days through urgent care rather than their primary care provider. And they went to urgent care and were given this or that and spent a couple weeks and it hasn't gone away or still there. So most patients have come in on treatment or have tried something on their own, tried Dr. Google and then tried something. And then some patients are, they figure out how to access dermatology on their own. They self-refer. They check their insurance and they contact and they come in and they decide that they want to see a specialist. So they don't give you guys the opportunity to take a whack at it. Yeah. Yep. Yeah. Yeah. The question was about telemedicine and video or photography for dermatology. So it's pretty cool. There's services now that you can do as a patient where you can send a photo of your growth, rash, etc., submit it online, and get a response from a dermatologist somewhere in the country or world. Most of those, it's a fee for service. You pay for it at the time you submit the photo. There are teledermatology consultative services that have been developed around the country, often to try and serve underserved populations, or there are some groups that are doing teledermatology to groups that are practicing in Africa or remote areas that send cases to dermatologists in the United States and Europe for review. So those are pretty cool. A colleague of mine and myself, Dr. Cheng, and I got a grant a couple years ago, and we do teledermatology now for the legacy primary care providers as a pilot program where they send us cases from their, they see in clinic, they send us a picture with a little bit of history, and then we respond back and say, well, we think it's this or that, try this or that, or no, they should see dermatology, this needs biopsy, it looks like it is a skin cancer. And that's gone pretty well. So that's been a little bit of a pilot program. So the current issue with telemedicine is reimbursement. and getting it covered. So that pilot program is free for patients. You know, it doesn't matter what insurance you have. But the transition is trying to figure out, well, how do you pay for it so providers will actually do the service? It's not too hard for dermatologists to see a picture and say, okay, it's this, that, or number 3, you know, and do that pretty quickly and be able to take advantage of our visual expertise and get some feedback pretty quickly. It's just a matter of who's willing to sign up to do that, because you ask busy dermatologists if they want to do teledermatology, and they usually say no. Yeah. So, yep. Other questions? Yeah.
Is there a malignancy that most commonly presents as a skin lesion?
I mean, an internal malignancy? Or yeah. So those are called paraneoplastic dermatoses, where we see rashes that suggest an internal malignancy. They're pretty uncommon. There's sort of a whole category of them. Technically, Sweet syndrome is a paraneoplastic condition, so they present with this rash, and if they've yet to be diagnosed with a hematologic malignancy, that's something we really chase, and they get a pretty big workup for that possibility. You can get Sweets outside of hematologic malignancy, but most commonly not. So that's one example. There are patients that present with intertriginous eruptions like the zinc deficiency that end up having a glucagon tumor. You know, that's a condition called necrolytic migratory erythema. There are patients that present with spiny growths on their palms and soles that's been associated with gastric carcinoma. So there's a whole there's whole chapters in textbooks related to rashes or skin findings associated with internal malignancy, but they're rare. Yep. Mm-hmm. All right, it's been great. Thanks for having me.